All right, good evening, everybody. I think we're going to go ahead and get started with our programming this evening. First of all, I'd like to thank everybody for taking time out of your busy days to tune in and get some of this really insightful and hopefully impactful information about COVID-19 and what you need to know to stay safe during this holiday season. My name is Brian Caldwell, for those of you who don't know me, and I'm tuning in this evening from Atlanta. And just want to go over a couple quick things about the presentation before we introduce our panelists. So just to let you know that the chat is to communicate with the group or just an individual. This session is going to be recorded and your video camera will start off, but you can toggle it on if you need to for some reason. And please keep in mind to keep your microphone muted unless you have a specific question to ask and are acknowledged by whoever's presenting. So just a couple ground rules to make sure that we are running smoothly. And now I'd like to introduce you to our panelists. So first of all, I'd like to introduce you to Dr. Ovita Fuller. She's a virologist at the University of Michigan in Ann Arbor, and she's got a really exciting presentation for us today. Next, I'd like to introduce you to Dr. Talia Phillips, who is a family medical doctor at Oaklawn Medical Group in Albion, Michigan. She's going to be providing a clinical and medical perspective for what she's seeing on the front lines and what you need to know from a doctor's perspective to keep you and your family safe this holiday season. So with that, I'll turn it over to Dr. Fuller.
All right, good evening. Thank you, Brian. Good evening to everyone, and we're very delighted that you could join in tonight for a COVID-19 conversations. We're in a very interesting time of history, and so the more we know, the better we understand. So I want to thank you and all your networks for tuning in. So that we have as much time as possible, I'll go ahead and get started with sharing the screen. So we are in a time of COVID-19 pandemic that we've never seen before. And so tonight we're going to have some COVID-19 conversations. This is about the fifth in a series that we've done recently, and you've already been introduced to the people that will be involved. Note that the recording will be posted on this particular website, and there will be a YouTube access as well. So where are we? What we're going to do tonight is I'm going to give you some background on where things are with this virus and where it came from. And then Dr. Phillips is going to give you a brief view into the clinician's world, and then we'll have questions and answers and conversation. Home for the holidays. As you know, we're in holiday season of winter 2020, and it's the perfect storm for COVID-19. I'm sure you've been watching the news and you already know this from just watching things. So hopefully you'll learn tonight why we're here, how we got here, what we can do about it, and what we have to do in order to get out of it through this winter season. November 2020, we find ourselves in a perfect storm conditions. There's a high surge in the respiratory virus infections. As you see the numbers go up, we're 3 to 4 times higher than we were at the peak point in July. You'll see that in a minute. We're entering the winter season. As a matter of fact, here in Dexter, Michigan, we ended up with snow on the weekend. So people cluster inside. We're coming inside. We're going to be closer to each other. This is a season of multiple holidays, and there's typical travel and gatherings. We had Halloween, which is actually part of the reason there's a surge now. We have Thanksgiving, we have Christmas, we have Hanukkah for some, we have Kwanzaa, New Year's Day, MLK Day, President's Day, Valentine's Day. So we're in a season of multiple holidays where the natural instinct is for us to get together. Human beings are just people who are social, or we are social beings, creations, and therefore we want to get together. Further, the fourth factor is that college students who have been away at school are returning home, and they will be home. For example, at my school, they will be away until January 19th. So this is a natural mixture of households. So this combines to predict what you've heard to be a very dark season or a very dark winter for COVID-19. Our purpose here tonight is to help you be a light in that darkness, a light of safety and understanding, so you know what to do and why you're doing it, and you can communicate that to others. Our takeaway tonight is that we want each of you to be informed and to be proactive with all the COVID-19 preventions, so to reduce disease and loss of life and long-term impacts. And if we do that now, if we're proactive now, that will prevent us from having to be reactive in a panic mode when we see our families and our friends getting sick and dying around us. So we want to be proactive, and here's why. So where are we? Where are we now? This slide simply shows you the data coming in from the developed countries, with the USA being highest among those in cases, and this is out to October. These show you, as I have done these seminars over the months, show you the numbers of COVID cases per day as they progress going up. So in September, 42 a day, 42,000 a day. 2 weeks ago, 159,000 in that one day on November 14th, new cases. On last Friday, 198,000 cases in the USA. So this is the curve that we are seeing with the cases in the USA. This is where we were in July. So the total number of reported cases, and we know for every reported cases, there are cases that are not reported. The total number is now at 12 million plus in the USA, with over 256,000 deaths. And that's what we know, meaning there are others that are not reported. So it's only taken 2 weeks to get from here to 2 million more. And so we're in an escalating surge time where we have to be proactive. We don't have a choice if we're going to control this. Where did we come from? Where did COVID begin? So let's take a look at that. First of all, I want to make sure everybody's together on some important terms. COVID-19 is coronavirus infectious disease 2019, which is the illness. SARS coronavirus 2 is the name of the virus that causes the disease. Sometimes we say COVID-19 virus. Well, I guess that's okay because it is the virus that causes COVID-19, but the official name is SARS coronavirus 2. It was originally called the novel coronavirus, and it was identified in 2019. This virus is a member of a well-known family of coronaviruses, and what has happened is we've had a natural biological event where a natural animal virus, and we think this one originally was in bats, moved into humans, and this is what's called a zoonotic virus adaptation or a zoonotic transfer. This happens all the time when we have swine flu or bird flu. We've had 2 other emergence recently of epidemics of coronaviruses, SARS and MERS. And there are also 4 other human circulating coronaviruses that cause really bad colds or bronchitis or laryngitis. So now coronavirus 2 is the 7th human coronavirus. It first emerged in Wuhan, China, probably in November of last year, with the first outbreak occurring in late December. In March 2020, the World Health Organization declared a pandemic because the virus had spread to all continents with over 118,000 cases and deaths. And now, 10 months later, we're at 58.7 million known cases of COVID-19 infection, with over almost 1.4 million deaths and over 40 million survivors. And I keep saying known because there are probably cases that we don't know about. 217 countries. So this is where we've come from in 10 months. And that's just a picture electron micrograph of the virus with the crown around it, which is why it's called coronavirus. This is a very quick timeline. I don't want to walk through the details here, but just to show you, the first cluster appeared as pneumonia in late December. By January 17th or 7th, the virus had been isolated. By January 11th, the first person in this group died. By January 12th, the whole genome of the coronavirus 2 had been sequenced, which is amazing. It had spread into other countries by January 24th, and then it was by March 11th declared a pandemic. Here we are today at 58 million cases around the world. All right, so this is what is causing these issues. This is a picture electron micrograph of coronavirus 2 coming out of a cell that it was produced in. So the cell itself would be bigger than my screen. And this is a very small area of the cell where you see multiple viruses coming out of one cell. So whenever a cell gets infected, the virus takes it over and produces hundreds of new viruses. It's very infectious and very productive. One virus is smaller than 1/10,000th of the width of a hair. So this is a very highly magnified view by Elizabeth Fisher of the NIH. How does COVID-19 virus transmit? So again, you're making lots of viruses if someone gets infected. The virus is made in the upper respiratory tract cells where it's inhaled in. It's an airborne virus. It's respiratory transmitted. The virus can spread to at least 6 feet from respiratory droplets and even further from aerosols that travel and remain suspended in the air. So we have respiratory droplets and aerosols that get put into the air when people breathe or sing or talk or exercise or cough or sneeze without covering your mouth. This is why a mask is so critical, that it keeps these material from going into the atmosphere and increasing the number of viruses that are circulating in the community for other people to uptake. The virus can also be spread by touching things that these aerosols or respiratory droplets have landed on, and then touching your face or your mouth. Once it's introduced into the respiratory tract, it travels down the cells, reproducing on the cells of the respiratory tract into the bronchi and the alveoli. So most of the virus is actually reproducing in this area until it spreads through the lungs to other places. About 40% of the spread is preclinical or asymptomatic infections. That means it's from people who don't know that they are infected. This is an example of why that's so important. This is a highly contagious virus, more contagious than influenza, and certainly more harmful than influenza or the common cold. The virus actually spreads again by respiratory tract contact. People who don't know that they're infected can spread the virus. And this is a great example of what had happened early on. Here's person A who traveled from Singapore to France to spend a weekend at a ski resort. He shared a resort chalet with 12 other people. At the end of that weekend, and then over the course of the next month, 21 people who were either in that chalet or in contact with someone in that chalet were infected. And that was in 3 different countries. So this one person over the course of a weekend, a 2.5-day weekend in a chalet, transmitted virus to, which ultimately ended up to 21 other people, a highly contagious virus. Here's another example. This one happened in my home state. This is an outbreak or a cluster at Harper's Pub in Michigan, where young adults often gather. In this particular case, this picture's from early March, but when the state reopened in June, people went to the bar, and obviously if you're in a bar, you're not wearing a mask, or if you're drinking in a bar, you're not wearing a mask. The upshot is that over 120 young adults tested positive after visiting the reopening of Harper's Pub. So they were all traced to this event. And imagine the people that they came in contact with over the state of Michigan. Again, here's virus egressing from the cell that it's made in. This is the picture as it looks in the EM. This is the colorized picture. So any gathering of people from different households brings a higher risk of virus transmission. The more people that get together, the longer time they're together, the greater the risk. This is why we're saying for these holiday seasons, don't get together with someone. Stay with your own household. I know that's unusual. That's not what we do for the holidays, but this 2020 holiday must be different if we are to save lives, if we are to get through this dark winter. Here's another example, a restaurant transmission. This came out of China in a report in April, where here's the restaurant layout with a room that had air conditioning flowing out this way and in this way, and there's 6 tables. Someone at table A was infected asymptomatically, did not know they had been infected. They were there with family members, but there were families from other families, B and at table C. At the end of the time of this outbreak, we see that people from family B and family C were infected, suggesting that the airflow carried the virus from this person to people either in their family or people in the neighboring tables. People out of the line of the airflow did not get COVID from this particular situation. So when we're in restaurants inside, particularly, there's a greater chance of breathing in virus or aerosols that contain virus. So then how do we navigate the holidays and the winter season? We're here tonight to say, please make a plan for safety, implement known preventions. We don't have anything at the moment except the public health preventions. And that depends on human beings making a very purposeful decision to do what is necessary to stay safe. Remain in your immediate home, in your family unit, assuming that no one is positive, and get tested. If you're a college student coming from a far distance, or if you're coming from outside, be sure you get tested and quarantine before you go to your parents or your grandparents or wherever you're going. Do not gather with others. After traveling, isolate as possible to protect your family. And we need to isolate somewhere between 10 and 14 days because that's how long it takes the virus to actually show up. And I'll show you that in a minute. If possible, get another COVID test within 4 to 6 days after arrival, which means that if you got exposed during travel, it should show up around that time. Always use the 3 WCTs. What are those? When you leave your home, wear your mask, wash your hands often, watch your distance, stay 6 feet away or more from someone. And don't feel bad about asking someone, would you please back up or let us separate a little bit, because you may be affecting their life and they may be affecting yours by simply saying that in love. Avoid crowds or confined spaces or close contact. And this is easier to do if you just plan to be home. If you have symptoms or if you find that you're at risk from contact with someone who is COVID positive or sick, then you must get tested. That's the only way to know if it's COVID. And I'll show you that there are many other things that have symptoms that are very similar. Testing is available at multiple sites. There's a CDC website where you can put your zip code in and find the nearest testing sites, or you can go to your own county health department site, and I'm sure they'll have testing options there. Trace contacts are important, and treatment. Right now, we don't have any real treatments for COVID for the average person. Consistent then pro-actions reduce the COVID spread and get us through the 2020 season. Wear your mask, wash your hands, stay at home. How do we know if it's COVID? We don't know. We're in a season where there's colds, there's viruses, there's influenza, there's bronchitis, there's asthma, there's allergies. So we don't know. The only way to know is to get a test. There are several laboratory tests, from a nasal swab and saliva, which measure the virus RNA, to a blood test, which looks at the antibody that's present, meaning did you have exposure to COVID-19 or coronavirus before? So the testing is critical. This is the CDC website. If you just put in CDC.gov coronavirus, it will come up. We have to be tested in order to know if it's flu or coronavirus or allergy. What coronavirus does to the body in COVID-19. This is a very important slide. So let me walk you through it. This is a person who is putting out aerosols and respiratory droplets. So if the virus were replicating in that person, these will be going into the air, and anyone nearby who doesn't have on a mask will be able to inhale the virus into their nasal passages, thus getting infected and becoming someone who then puts virus back into the environment. This is a timeline from the initial exposure. The virus can actually show up between 1 and 14 days. Most typically, if someone is going to have symptoms, they will appear somewhere between 5 and 8 days after the initial exposure, sometimes sooner, sometimes later. Importantly, however, virus shedding, that is putting virus back into the environment, can happen as early as 2 days from the time of exposure, well before symptoms appear. So someone can be pre-symptomatic before they get any clinical symptoms. So clinical infection, recognizable symptoms, whether the disease turns out to be mild, moderate, or severe, or subclinical asymptomatic infections, can expose people to virus before the person knows they're sick. Once the virus is in, then the person is shedding for the rest of the time until they're completely well. What are the symptoms? Fever, headache, cough. I'm told the headache just won't go away, a dry cough, often a loss of taste or smell. And sometimes we don't see any of these symptoms, or we see some combinations. The contributing factor as to what happens determines on how much virus is encountered. So how long are you around someone? What is the status of your immune system, of the person's immune system? And then what underlying conditions are there? So this is a very important concept to understand, that virus shedding is occurring very early on and throughout the infection. What are the symptoms, and how does infection or exposure progress to disease? The common recognized symptoms, or any combination, some people have some have others: dry cough, a shortness of breath that comes on suddenly, fever and headache. It can be a low-grade fever, muscle pain and tiredness, purple toes and fingers from a change in blood clotting or blood circulation, and loss of taste and smell. This is because the virus is reproducing initially in the nasal passages and then traveling down the windpipe. It produces in the mucous membranes of the upper respiratory tract, just like flu does, but the symptoms with COVID can come on very suddenly. The immune response, what the body does, along with the virus replication, can then lead to mild or moderate or severe disease for some people. What does the progression to more severe COVID look like? So when the virus moves down the windpipe into the lungs, there's a battle between the host defense response. All of us have some immune response, unless we're immunosuppressed. So the immune system goes in to attack the virus. The virus is trying to reproduce itself. So there's a battle that's set up, and that leads to inflammation and cell damage and excess mucus. The virus can move out of the lungs into blood vessels using ACE2 receptors, which are very prevalent on cells throughout the body. About 80% of the people that get infected will have no symptoms or mild or moderate symptoms. They'll be at home. They'll be stuffy. They'll feel terrible. They'll feel like they got hit by a truck, but they will not need hospitalization, but they can transmit virus. About 20% of the people who get infected will progress quickly to severe disease. Sometimes people who are having moderate symptoms, instead of getting better, also progress to severe disease. What happens in severe disease? How does COVID or even influenza lead to pneumonia, which is a major problem? So again, we have infection plus the immune response in delicate lung tissues. Here's what, and I didn't mention this, but here's what the X-ray of a clear, healthy lung looks like. You can see through the air sacs there. And so if you take an area and magnify it, this is what the air sacs that exchange oxygen and CO2 in the lungs look like. These are clear openings where one can get oxygen in and CO2 out. These are little air sacs. That's what's healthy. When one is infected with a virus that can lead to pneumonia, there's swelling due to virus replicating and immune response in those alveoli, which clogs up those air sacs to cause inflammation, which ultimately leads to a buildup of fluid, which is known as pneumonia. This is an X-ray of a person with pneumonia. Instead of the clear lung exchanging air, now there's fluid and the person can't breathe. This not only causes difficulty in breathing, but it also leads to restricted oxygen in the bloodstream that has a major impact on other organs, liver and kidneys and heart and skin. So this is the difference between a healthy lung and a lung that's been infected with a respiratory virus, COVID-19 or influenza. There are a wide range of body effects with COVID-19. They can range from pink eye, which is relatively mild, to brain strokes and blood clots, which are seen very frequently in COVID patients. Loss of smell is very common. Blood clotting, gastrointestinal issues, vomiting and diarrhea happens with some people, and you'll hear a little bit more about that from Dr. Phillips in a little bit. Lung clogs, heart muscles and arrhythmias, heart attacks, kidney damage. Many of the severe patients end up on dialysis to try to help them recover or save their lives, and many of them don't make it. Skin, there are issues with blood clotting such that we end up with purple rashes or toes or fingers that turn a different color. And then the immune system is impaired. So even if you have a mild case, your immune system may not be able to fight off exposure to influenza or tuberculosis or some other pathogen. When we have someone who is severely ill and going through many of the things here, they're either given oxygen to support them or mechanical ventilation. And that's to try to help the lungs to produce oxygen and to keep from having multiple organ failure. How this support works determines whether a person survives or dies from COVID-19. So there's a wide range of symptoms. There's something also for people who have mild symptoms called long haulers, meaning that they actually don't ever quite get over all the symptoms, all the way from brain fog to shortness of breath to hypertension to joint pains. This continues. I know people who got infected in April who are still having symptoms. These are called long haulers, and that can happen even with a mild case of COVID. On the left here, I want to show you that all age groups get infected. This is a virus that doesn't care who you are. It just wants to reproduce itself in a human. But what I want you to get is the people who most often die from COVID. As you get older, the red data goes up, the red bars go up, suggesting that people whose immune system or who have underlying conditions are more at risk of death. And this is many of your grandmothers and aunties and uncles, people you care about. So you don't want to carry this virus to them or anybody during this holiday season. Just because this is important to know, COVID has revealed health disparities. So just showing you a little bit of data here from Milwaukee, Chicago, or North Carolina, where the percent of the African-American population is 26%, 32, or 21%. The percent of deaths from COVID early on in May were very, very high. 73% of the people in Milwaukee County that died of COVID were African Americans, or 67% in Chicago, or 38% of the people who died from COVID in North Carolina were African Americans, even though the percentage of the population was 21%. So this has disparities among people of color. And this just shows you the data by cases, looking at from Latinx to Asian to white to others. Here's cases, here's deaths, and these are African Americans. Why is that? There are many reasons, and we don't have time tonight to really talk about that, but I want you to think about these things and what we can do to stop the misinformation, how we can get better access to medical care, how we can make sure we take care of ourselves, and we know that we're on the frontline jobs of making the country run. All right, so in getting to my last few slides, how do we reduce the risk of coronavirus and other airborne transmissions? So here's the risk chart, going from highest to almost no risk. And we want to be down here in the lowest or no risk for the rest of this winter. If you don't wear a mask, then you're just at the highest possible risk of putting COVID into the air and infecting somebody else or getting infected. It's good to wear a mask to protect yourself from other people, but it's even better if you protect yourself because you may be asymptomatically putting virus into the community. It's even better if everyone wears a mask, the person who's uninfected and the person who may be asymptomatic. So if someone travels home from a place, be sure that you wear a mask and the people in your household wear a mask. And even better, stay 6 feet apart and keep a window air open or keep some air circulation going. If you're out, certainly stay 6 feet away from other people and wear your mask. The best way to prevent or reduce risk is to stay home with people you know who are quarantined or who are isolated. And if there are people who are not isolated, make sure that everybody wears a mask. These are the best conditions for a safe, merry, and happy holiday season. Remember, virus transmission is highest among asymptomatic or pre-symptomatic people between 2 and 5 days after exposure, before you feel sick, before you know anything is wrong. All right, so how do you wear a mask? Let's be sure you know how to do that correctly. Remember, these aerosols and respiratory droplets are going into the air. A mask will, especially an N95, will stop 90–95% of the large droplets in the aerosols, but even surgical masks and cloth masks stop about 70% if you wear it correctly. How do you wear it correctly? You must, one, make sure your nose and your mouth are always covered. It doesn't help if you start out with it covered and then let it slip down. You want to keep it covered so that these this material is not going into the air if you are infected, and you're not breathing it in if you're not infected. You want to make sure there's a tight fit around the cheek. You want to be sure not to touch the front of the mask because that's where the virus and the aerosols collect. You want to be sure when you take it off that you put it someplace where it can be washed or it can lie around so the virus on it would decay if there's any on it. And then you want to be sure you wash your hands before you touch anything else. Wear the mask correctly all the time. Sometimes we get comfortable around people and we take them off, but that doesn't help. We have to keep it on. All right, so how do we mitigate loss? Use the public health infection preventions. That's all we have. We don't have a drug. We don't have a vaccine that's available yet. So physical distancing, you've heard these, but I want to reiterate them because they're so important. Stay home if you don't have to be out. Limit the size of gatherings or don't gather with people outside of your own household, your own family. Correctly wear a mask when away from home. Clean the surfaces, frequently wash hands, and don't touch commonly used items like doorknobs or handrails or elevator buttons. Get a test if you think you've been exposed, or get a test just because you want to know if it's available. If you are asked to contact trace, give them the information. If you're asked to isolate, isolate. Protect and monitor our frontline workers. You're going to hear from one in just a moment. And then we're doing research as best as possible to develop antivirals and vaccines. And in the last couple of slides, I just want to update you on the vaccines. This is the process, a very rigorous process of getting a vaccine or antiviral to approval through the various laboratory phases to the 3 different clinical phases. We see that there are many COVID-19 items that are in the pipeline, with now about 12 that have reached the large scale phase 3, where we have to have thousands of people because we're looking at it over a shorter amount of time. Normally a phase 3 trial would take about 5 years with about 3,000 people, but because we're reducing the time, we have to increase the number in order to get data that's reliable. And so we have 12 different reagents that I know about that are at this phase 3 clinical trial. You've heard about 3 that actually now seem to have some data suggesting that they are effective. They have not yet gone into review by the FDA that I know of for FDA approval. So they have to be reviewed. The data will have to be looked at, and they will have to get approved before they can be used. So this is where we are with the vaccines, and we can talk more about that. The takeaway message then is we don't have anything except public health preventions right now. We must be proactive right now in this dark season to always use the preventions available to us. Make and implement a plan for you and your family and those you care about for the 2020 season, not just Thanksgiving, but Christmas. Zoom together or plan a Facebook time or do whatever you need to do, but make a plan so you don't have to get together. Expect to require a model compliance by individuals, by families, by leaders, by others in the community. Do it with love. Tell them, I love you, but I can't come over there, Auntie. Do not gather away from your own household because the risk is too great. Know that it takes a minimum of 10 to 14 days before what we do shows up in the stats. So what we saw happening in November 2 weeks ago came from the Halloween and the trick-or-treating and many other things that were going on. Remember that every one infection that stopped can prevent at least 5 other exposures. And then very importantly, practice self-care. You have to take care of yourself because we can't gather together for that emotional support that we usually do. So do things purposely for emotional, mental, and spiritual well-being. The bottom line is each person must stay diligent to do what we know and vigilant to watch out for others. So this is the foundation that I wanted to give you for our conversation starting tonight and forward. We will continue the conversations. We say that you should continue the conversations with others. What can one person do to make a positive difference over the 2020 holiday? That's the question. And we know that you can proactively do the preventions so that others will not get infected. So I'm going to stop here and turn you back to our moderator. Brian, are you there?
I'm here. Excellent. Thank you, Dr. Fuller, for that insightful information and kind of the foundations of the science behind COVID-19 and the story from where it started to where we are now. Now I'd love to introduce our clinical guest tonight, Dr. Talia Phillips. Again, for those who just joined us or didn't hear the beginning, she is a family doctor at Oaklawn Medical Group in Albion, Michigan. And I want to turn it over to her to talk about what she's seeing on the front lines in the clinic and day to day with the people that she's treating. So Dr. Phillips, are you with us?
I am. Can you hear me?
We can hear you. Awesome.
Oh, praise the Lord. Good evening, everyone. So grateful for this opportunity just to share the realities that we are so clearly and presently facing. So I am Dr. Talia Phillips. I am honored to serve as a family practice physician in the Albion community. And when I tell families or patients or persons is that I'm blessed to serve people from birth to glory, right? And so the age demographics that were discussed by Dr. Fuller Caldwell are those that I see every day. In addition to being a physician, I am honored to be a wife and a mother of 6 children. And so it is in that understanding, that lens that I live every day as a wife, a mother, and a physician. And so I want to share with you all that my colleagues and I who are serving in medicine have kind of 2 mental guidances as we move through our clinical days. And one of those guidances is that minimize contacts, minimize transmissions. And so as we are moving through every day, we are recognizing that our goal is to minimize contact with other human beings, because the second mindset that we have is that we assume that everyone is possibly positive. And so that is the assumption that we're moving in, where we're encountering another person, whether it be our staff or our patients that we're serving or their families that are supporting them and bringing them to appointments. We are moving with the understanding and assuming that they are possibly positive. And a lot of that has to do with what Dr. Fuller Caldwell had mentioned. There are so many patients and persons that are moving through our communities in this season who are unaware that they are carrying and transmitting the virus because they are asymptomatic. And so I was asked to kind of share about what my day looks like. And so we rise very early in the morning to prepare our children for their virtual school day. So this pandemic has impacted them. So we house 6 children in our basement in a homeschool from ages 4 to 16. And that in itself is a whole nother concept that we don't have time to delve into, but recognize that the healthcare providers who are serving you, but also serving you with the other areas of their life that are coming along with them. And so our children are virtual because we, again, recognize that contact means transmission. And this virus is impacting every age group. And we did not want that to be a possibility for our children as they were trying to grow and learn academically. And so then I prepared to go into my office. I am a physician who did not regularly wear scrubs, and I have been wearing scrubs every day for the last 8+ months. And it is because I realized that my body and my carriage can also be carrying the virus. And so I put on scrubs every day and step foot into my office. And there are temperature checks and screening questionnaires that me and all of my colleagues and staff have to go through before we walk into the office. And every personal contact that I have with the patient, I am to be equipped with a gown, N95 mask, and a face shield. And a lot of what I am wearing is because we know the prevalence and possibility. And so when I'm talking to patients, I'm explaining to them through all of this attire that I'm wearing this because I'm aware of the risk. So this is the reason why we say when you're going out, if you have to go out, make sure you're wearing your mask, because those of us who have the knowledge base understand the seriousness and the heaviness of this experience. And this is how we're responding. This is how we're arming and equipping ourselves. We recognize that some of the patients and families that we are serving are going out without any protection whatsoever. And that is alarming and concerning to us for their well-being. So please do not go out if you don't have to, because when we go out because we're knowledgeable about what we're trying to protect ourselves against. And if you must go out, yes, please properly protect yourself. The other thing that we've moved into in the realm of medicine is to virtual visits, telemedicine. So in March, our organization, I'm blessed to serve in a primary care clinic and in a group, but we are wonderfully partnered with the local hospital. And so I serve in the outpatient setting, and my colleagues are also those who serve in the inpatient setting. And both of us are impacted in serving patients who are COVID positive, who are fighting the battle of survival and for wellness in their homes and in hospital wards. And one of the things that we had to quickly adapt to is telemedicine. And we had to do it in a way that would help us serve our patients, patients who did not have cell phones, who did not know how to use technology, who did not know how to use gadgets and FaceTime and Google Meets and all the wonderful things that we have learned and grown to use more effectively over the last 8 months. And so my staff not only were clinical staffs, but they were IT technicians and advocates for patients and their families in terms of trying to cultivate connection, so that in this process of trying to stay safe and creating distance and protection for our patients, no one got lost. And so I'm grateful for grace because in the midst of the last 8 months, we've been impeccably surprised by how the patient populations have adapted. Unfortunately, they've had to adapt, but they have successfully. I have 94-year-olds who are doing telemedicine visits with me better than my 32-year-olds. And so we as humanity have evolved, but we also have to recognize that in this evolutionary process, we still have to practice wisdom. I do want to honor our time. And one of the things that was most valuable to me was to answer the questions clinically that you had. And so in this moment, I hope that did what you wanted me to do, Brian, in terms of painting the picture of what life looks like, at least in the clinic. And I'm happy to address any clinical questions that any of our friends online would like to ask.
Sure. So if you guys have questions, please put them in the chat. And I've got a couple already here that we'll get started with. So Dr. Phillips, have you seen patients in your clinic or through telemedicine that were at the point where they were so severe that you sent them to the hospital?
Absolutely. I was on call. On call means that my phone is accessible to any of the patients that we serve in our medical group 24/7 on Saturday. And I received my office manager 62 calls.
Wow.
And one
62 calls this past Saturday.
This Saturday, I got 62 calls. Literally, it was like I would walk out of the office, my home office, right? Because it's Saturday, and I would walk to the next room, which is my kitchen, and before I could make it fully into the kitchen, my phone would ring again, right? And about easily 70% of the calls were because patients were having COVID symptoms and needed to be tested. One of the calls that I received was for a patient whose vitals were plummeting. And the only thing that I could do in that moment was to instruct the family to call 911. And so, yes, that is something that I am seeing very presently. And the reality of patients getting to that very dire state is heartbreaking. But the heartbreaking piece for us clinicians is that we do know that it is potentially preventable. And so we have to do everything we can as a society, as humanity, to, yes, protect ourselves, but also protect those that we are sharing humanity and creation with. So please be mindful of, yes, your safety, but also the safety of those around you. Yeah.
What we've said is that love is in action at this point. If you want to model being a human being, you not only protect yourself, but you protect others by following the prevention guidelines.
Absolutely.
Yeah. Thank you for that. Next question I have for you, Dr. Phillips, is in regards to long haulers, which Dr. Fuller touched on, but have you seen patients with long hauler type symptoms? How do they present, and kind of how do you manage their care long-term?
Very plainly, they present frustrated, right? Because these are patients who I've served over the course of 4 to 6 months, where they tested positive 4 months ago, and they're calling because they're still exhausted. I've had actually probably 10 patients that I can think of that their response is that I can go to work and I can do my job, but by noon, I feel like I've hit a wall and I need to take a nap. Now, these are individuals who were at the top of their health game. They were athletic coaches at collegiate levels, and they are exhausted. And unfortunately, what I have to tell them is that I do not have a solution. I do not have a cure. I do not have a fix. And I do not have a time frame for when this will be over, right? Dr. Fuller Caldwell had shared the truth, right? We in medicine do not have a cure, right? We don't have a solution. I don't have a magic medicine. I don't have an antiviral medicine that can make this go away. But what we can do is try to prevent it from making the impact, as much impact as it has been making, because the long haulers are struggling, and I don't have an answer or solution for their struggle, but to give them support and encouragement.
Yeah. I have some friends and colleagues personally that got the coronavirus, COVID-19 months ago, back in the spring, and they're still struggling with various symptoms now, of all ages too, and all different pre-existing conditions and statuses.
I have students also who are long haulers at my university as well. It's very common.
Yeah. Okay, next question I have for both of you. We've heard that people have this relative immunity if they've tested positive for COVID-19. How long does that last, and what other precautions or prevention should someone take if they have in fact tested positive at some point, or come down with symptoms?
Dr. Phillips, why don't you take a stab, and then I'll close out that one.
Yes. I was just reading our latest medical update from one of our medical journals, and it was saying we have no evidence. There is no clinical evidence that has been provided that said that there is this ideal of immunity that is protracted or prolonged, and there's no timetable that tells us how long this immunity lasts. And so what we tell patients is that if you've been positive, guess what? You can be positive again, right? Because the truth is that we do not have scientific evidence that says that once you've had coronavirus and tested positive, that you have a lifelong or a long immunity against contracting it again.
Actually, we have cases where people who were documented to have gotten infected with coronavirus and had cases of COVID get reinfected, and some of them it's very severe the second time, or more severe. So the bottom line is we don't know about what the immunity to COVID is in terms of how long it will last. And we've heard about the vaccines and their protection so far in the initial studies. The question is, how long does that protection or that immunity last? The answer is we don't know.
We don't know.
And we know that people have been getting human coronavirus for years, a different kind. So what will it be for COVID? Time will tell.
Absolutely. And the reason why it's worse with the reinfection is the same reason why Dr. Fuller alluded to that slide about the overwhelming impact to our holistic immune system and our body organ system when it's trying to deal with this virus. It is a multi-system impact. It is impacting the respiratory system, the vascular system. It's impacting the muscular system, the immune system. And so it takes a long time for your body to recover from such a widespread insult, and reinfecting yourself when it's already struggling to recover is just a very potentially dire experience. So please.
This is why also, if someone is in your household and you say, well, I've been in this household with this person, I'm sure I'm not going to get infected. You probably will get infected. And then the two of you need to try to stay isolated, because you can reinfect or re-expose each other to more virus. The more virus you get in your respiratory tract, the more difficult it will be for your immune system to survive it and get past it. So reinfection or continued exposure is not a good thing with any virus, but particularly with COVID-19. Also, the receptors for the virus are not only in the respiratory tract, but they're all over the body. So that's why we also get some of these symptoms that are very broadly shown here. It's not something that you want, even in a mild case. I see there's some questions in the chat also, Brian.
Yeah, absolutely. I've got one that's a two-part question from two different folks here. how long does COVID-19 stay in the air, and how long does it last on surfaces? And what's the surface transmission risk, as far as folks wiping down their groceries and
Sure.
doorknobs and all sorts of stuff,
Got it.
after any chance of exposure?
Yeah, so first of all, let me say when COVID-19 first came out, we didn't know a lot about these things. And so there were some studies done that show that the virus can remain for 24 to 48 hours on certain surfaces like metals or cardboard. What we're seeing now is that the major way that COVID-19 or coronavirus is transmitted is through the air. It is probably 70 to 85% of the infections are airborne infections. There are times when you touch a doorknob or you touch something and touch your face that you can contaminate yourself. And that's why our clinicians also are degowning when they leave the clinic place. But wiping down your groceries is not necessary. I did it early on. I don't do it anymore. What you can do is leave things in a garage or someplace to for a day or for a while to let any virus. This virus dries out if it's left on a surface for a very long time. So you can do that. But really, the great things that we all could do is simply wear a mask and exercise those public health preventions. The things we were doing to avoid packages and things, those are good. But the real thing we need to do is not to come in contact with one another and breathe in aerosols. That would take the numbers, plummet them down to the level of infection.
Understood. Thank you. The next question I have from the audience is about vaccines and their safety. And I know there's been a lot of back and forth and unfortunate misinformation going on about the vaccines and their relative safety. Can you talk to us about maybe a little bit about the vaccines and how safe they are to take, or if there's any side effects that someone might experience from taking a vaccine?
Well, first of all, let me say everybody should be sure this now to get a flu vaccine. You should have been getting it before, but this year is critical to get a flu vaccine. The flu vaccine is a dead virus for most people. If you get injected, it's a dead virus. It's only live if you take the flu mist, which only a few people get. A dead virus cannot make you sick. What you feel is the result of your immune system attacking the virus that's put in, the dead virus that's putting in, to prepare to get rid of it, which is good because that leaves a memory then that's going to see the real virus when it comes, and you'll be able to not get the flu or to get a much milder version. So it's so important this year to get your flu vaccine every year, but especially this year because we can't tell the difference between the initial symptoms of influenza and COVID-19. So if you know that you're not going to get pneumonia likely from flu because you got the vaccine, then that means that any deeper symptoms that come, you immediately have an idea that it's COVID, or if it gets better, you say, oh, that probably was the flu, or better yet, get tested. So in terms of the vaccine, we don't have a vaccine for coronavirus. You're hearing things on the news. These are the initial data that come out of the studies that are being done, and there are quite a few being done. If one of those is approved, and I suspect one or more will be approved, we probably will have a pool of vaccines that vary from just the RNA to the part of the virus on another virus to other products. And so some of them will work better in some people, some in others. The bottom line is the vaccines are first going to go to the frontline people like Dr. Phillips and the nurses and those people, and even people who are out doing other things. Probably by March, we'll start seeing vaccines for everybody, for the most, and maybe a little bit earlier for the most at-risk people. It won't be probably until June or July that the average person will have gotten vaccinated. And then it takes somewhere between 2 to 4 weeks for the immunity to set in. So I would say by next year, by next year in September, we will probably be where many people have gotten the vaccine. What's going to happen in game? We will still have to use masks when the virus level is up to a certain amount. So we will still be monitoring the number of COVID cases. When it's low, we'll have a little bit more freedom. You'll maybe wear a mask only if you're out shopping in a place that's crowded. But in a day-to-day sort of thing, you might not have to wear a mask because the amount of virus is low. But if it goes up, we're going to be masking up. So it'll be a combination of preventions that we know about and letting the vaccine work and more people get vaccinated. We don't have it yet. We probably won't have it for everybody until probably, I'd say, May, June, July. Dr. Phillips, I don't know if you have any other to add to that.
Yeah, from the clinical side of it, we do not have the capacity in terms of having a conversation, a consult, or assessment with the patient to determine if you have influenza, RSV, which is in the respiratory virus, primarily in pediatric patients, or coronavirus, right? So we have to do the testing to determine which one you have, and recognize this process for even getting the test and getting it done in a safe way with all of the parameters that we have in place is complicated, right? And so if you can mitigate the reality of you having one of those three, help yourself, right? Because there are co-infections that happen. There are times when patients have multiple things systemically happening, multiviruses that are happening. We do in our office space have the capacity to do 3 tests with 1 nasal swab, and that was a luxury that took us months to get it. But just in a telemedicine encounter, or just in a patient calling in and saying, you know, I have X, Y, and Z symptoms, we do not have the capacity to distinguish which one you have. And so again, prevention is key. And if you have not gotten your influenza vaccine, please help yourself, especially if you are going to be in public spaces. You need to protect yourself.
Brian, I want to add to, we're at 8:30, but I want to add something about the vaccines, is that when you have an opportunity to get it, it depends on the kind of vaccine. You need to find out more about it, what kind of vaccine it is, what are the drawbacks of it, what are the pros of it. You need to do your due diligence about the vaccine. But yes, there's several vaccines, if they were approved now, if I saw the data, that I would take rather than risk getting COVID. So, but you have to do your due diligence to see, should you get the one that's the messenger RNA only, which means there's no virus, or should you get the one that is the virus plus adenovirus, another virus, plus a piece of coronavirus? And what are the side effects of each? And how long does the data say they last? We don't know those things yet. They've not gone through FDA. So yes, I will get a vaccine after it's gone through the rigorous FDA approval. And I will ask my physician, which one is it? And which one should I get? And hopefully he or she will be able to give me some insight, or I may know myself. But yes, a vaccine is safe, and it will, and I know we all have these issues with things we've heard about vaccines, but at this point, they go through the trials to show that they're effective and safe, and it's a rigorous process.
Absolutely.
Excellent. Thank you guys for that. I know I want to be mindful of everyone's time, so it's just a little bit after 8:30. Thank you if you have to jump off. We really appreciate you attending this evening, but we're going to keep going probably for another 15, 20 minutes and continuing to answer questions in the chat. So if you can stick around, and we'll continue to learn together. So the next question I have is from someone who has to travel. And the question is, if someone is traveling internationally or even just domestically and has to do that, what can they do to do so safely? And we'll start with Dr. Phillips on this one.
Absolutely. Well, I feel like Dr. Fuller-Caldwell did a great job walking through the details, so I'll reiterate them. What you should be doing is doing a test. You should get tested before you travel, just for your sake, but also for the sake of those that you are traveling to see. You should maintain social distance, which in my brain, I can't even conceptualize the capacity to do that in an airport or a train station in a way that would in any way, shape, or form seem safe. But again, I know reality in life happens, but you want to try to maintain as much social distance, and you really want to be masked properly. If you have the capacity to have N95, I'm going to be honest and say get one, right? Because she showed us the picture of the level of protection. And so if you're going to be in these very public spaces where transmission risk is high, then you need to do everything you can to try to buffer yourself and put a barrier between you and the virus. Any virus, right? Yes. SARS, COVID, but also influenza, right? And so those are some things that you can do to be intentional. And then, like she said, when you arrive, you do want to be retested. This reality of being asymptomatic and spreading the virus days long before you even know is a very real thing. I just had a family that I was serving who was vacationing in Florida, right? And came back a week later, and the persons that they were with ended up developing symptoms 2 days ago. So now they're in quarantine. And so just understand that as you're moving through this process, you have to plan, and you have to be mindful of these 2 and 14-day windows so that you can be safe, and the people that you're going to see can also be safe. And so if you're going into someone else's home and you have not been tested, again, recommendations and guidance is that you would be somewhere separate from the rest of the people you're going to see for 2 to 14 days. That's 2 weeks. That's longer than most people are going to be there vacationing with somebody.
That's right.
So we just have to really, really think through these processes and ask ourselves, is it necessary? And if it is, just understand the weight of responsibility that goes with that, right?
So I would say don't. International travel is not the thing to do right now. As a matter of fact, there was just a report that came out yesterday or the day before about someone who traveled, I believe it was to New Zealand, and that a large number of people were documented to have been infected from that asymptomatic person on the plane. If you're traveling for particularly a long amount of time, it's no way you can keep a mask on the whole time. And we know that the more that you're in the setting, the longer you're there, the higher the risk of breathing in virus. So I would say if you must travel, travel by car if you can. First of all, don't travel. Don't. This is not the year to do it. Don't do it. That's the best thing. Right. If you're traveling, travel by car. Make sure you have your food. Make sure you have plenty of water and everything you need, so you're only stopping for restroom and gasoline. Mm-hmm. And then when you do get out of the car, wear your mask, have your alcohol, hand sanitizer, don't touch things. I either have gloves or I have something between my hand and anything that I touch. Before I get back into my car, I'll open the door and then I'll use the alcohol swab before I touch the steering wheel or whatever. So that would be the recommendation. Don't travel if you don't have to. And unless it's an emergency, I would not do any international travel because that's by nature a long time on the plane. And we now have data that shows that even the best preventions cannot keep you safe from a long time.
Yeah. I would honestly say easily of my patients who have been positive, and it's hundreds, I would venture to say that 60% of them were positive and exposed during travel.
Dr. Phillips, a question for you. When you say your patients who are positive, so we see this surge, right? And yes. Have you seen that surge in your clinic? I mean, we see what the data look like once it's reported. Yes. But can you say that over the course of the last few months, you've seen the same sort of surge in terms of the number of people reporting to your clinic that this yes. is the picture that have
absolutely.
COVID? So it's real people. It's not
It is real people, and it is real school districts, and it is real families, and it is real hospitals. So the initial experience for us at our space where we serve was in March, and our staff numbers of course got cut because it just is a reality, right? If we're seeing less patients, then there's less people who are in these spaces, and we triage them to the hospital where there's more need. And so there was an initial, oh amen, I'm sorry.
Okay, so this is real people.
See, she's
this
a
is real
person, even.
Amen. This is real people. This is real people. The other impact, I'll be honest, is that we are seeing that there is a lag in the testing process, right? So there are some spaces and places where testing is being done, and the test turnaround for response is same day. That is not the norm, right? In the clinics where we serve and in the hospital where I serve, they triage them. So there are patients who are inpatient who they need the immediate turnaround, but most of my patients are waiting 3 to 5 days for the test result. So for that entire time, they are quarantined, right? With their families waiting to know what the response is. And so there's also a lag in that process. So, when you see some of these jumps in the numbers, it's actually data from 3 to 4 days prior.
That's right.
And we're just finding out 3 or 4 or 5 days later that this cluster of persons have been positive.
Remember,
and in regards to testing too, I've got a question from the group here. Is there a test that's a preferred test between the PCR or the rapid test or the antibody test? What are all tests created equal or not? Why don't you talk to us about that, Dr. Fuller?
Well, Dr. Phillips, let me let you take that one, but let me say, because I know some people have to leave, that remember the darkest hour is just before dawn. We are in this process of going through a winter of a perfect storm where what each person does makes a difference to how this coronavirus pandemic will ultimately, whether it'll keep going and next Thanksgiving and next Christmas, we'll be doing exactly what we're doing now, except we'll have lost a lot of people because they won't make it through this year or through the next 6 months or 8 months. So what we do now really, really matters. If we can get through this time with mitigating loss of life and loss of health, then we'll get to a season where we have vaccines as well as the preventions, which will keep the virus lower, which means we won't have as difficult a job to do. So if you take anything away from tonight, that is now is the time to be as rigorous as possible. Tell your grandmothers and folks, tell your nephews and nieces, if you want my mac and cheese, you just have to come by. I'll set a plate out on the front porch, or I'll put it in a container and put the top on or whatever, but you cannot come in my house this year because I love you and you love me. That's love in action. And that's what we're trying to say. Now you know why you really do have to do that. We have lots and lots of questions and we could keep on doing this, but the take home is you are the ones now that now you know you have to do. Love is action. If you love somebody, or if you're going to be a good citizen, you have to do this.
Absolutely, absolutely. My brief response to are all tests equal, or which tests did we get? You should get the one that you have access to, right? Because on a day-to-day experience, we just need to know as clinicians, positive or negative, right? One thing that our clinical perspective is about this antibody testing. We don't recommend that patients do that at this point because there's not enough data that supports the value in it. So I would not recommend, and honestly, insurances are not paying for it. So patients are paying like $85 out of pocket to get it done. And again, there's no clinical validity to that testing. So get the test, not serum, not blood draw. Get the test, nasopharyngeal, oral, that you have access to in your community. Just get the test, right?
Also know that a test is just one snapshot at that moment. If you test negative today, but you thought you got exposed 3 days ago, maybe, possibly in travel, and then you get a negative test today, particularly if it's only 3 or 4 days after, that may not mean that you're not exposed. It just means that there's not enough virus that was detected at that time. So if you get symptoms later, go get another test. Or even if you don't get symptoms later and you can get a test, get another one through those 14 days to make sure that there's no virus coming from you asymptomatically.
Our clinical recommendations is if a patient presents with symptoms, and she showed you that whole list of symptoms, and literally I've had patients who've had just nausea and vomiting, diarrhea, and that patient was positive for COVID, for coronavirus. So the reality is that we tell patients, if they call me or call my staff and they have started experiencing symptoms, we tell them not even to get tested until 5 days after the onset of symptoms. And it's because we know we need a high enough viral load to capture accurate data. So if you test too early, patients will be walking around thinking they're negative, and they'll be transmitting it to the community and the people that they love. I had one patient and one family where the patient got tested 4 times, and it was not until the 4th test that he tested positive. 4 tests. Hear me say that. It is so important that if you have symptoms, please self-quarantine. Please have your families stay safe and stay in place, because their likelihood of you being positive is significantly high.
Yeah. So, I mean, that brings up a really great point. Let's say, all right, we should not travel at all, but if we have to travel, like, you know, if you're going to see loved ones and you just have to go, if you fly, it doesn't make sense to get tested the same day you land, or even the day after, or the day after that. You need to quarantine for at least 2, 3, 4 days before you get tested to get an accurate idea of whether you were exposed during that trip or not. Is that correct?
Absolutely. And for that 2, 3, 4 days, you should not be around the people that you traveled to go see.
Yeah.
So if you're going for the Thanksgiving holiday, it defeats the purpose. You're really just risking yourself and people that you love by going for a short amount of time. Is this making sense to you all? Please, can you just nod your heads? We are not trying to put you in a panic, but we are trying to get your attention in a way that says we are in a crisis, but we're in a crisis that we can help get ourselves out of with everything that we have. So rather than react because somebody in your home or your family is very, very sick, and think about all the people who get sick and can't be with their families. Also, the increase in COVID is going to affect the rest of the healthcare, right? So for things that don't have to, that are not COVID, if the hospitals and medical clinics are filled with people dealing with COVID, then the rest of us are out of luck. And I know that that's the case because my own mom was sick in a time when there was COVID and I couldn't go be with her. So you don't want that to happen. We are in control of this destiny by individually doing what we can.
Can I just say this last thing? The impact is so widespread on so many levels. Like just a simple example, I have a patient who does not have COVID, but who had other realities and had to go into inpatient rehab. So this patient, because of the realm that we're living in right now, has no contact with his family. So they have to wave at him outside the nursing home through a glass door, because of what we're in the midst of. And so just the impact of what we're in the face of is so great. I mean, the school districts and the teachers and the job losses. And so please, just again, recognize the decisions that we're asking you to make in terms of staying home and staying safe are really for the sake of humanity. It is for the sake of the livelihood of this nation, of this globe. Please recognize the greater impact.
Yeah. Well, guys, we are just about out of time here. And if there's any other questions, I'll make sure that they get forwarded to Dr. Phillips and Dr. Fuller. We really want to thank you guys for tuning in, as I said, for this really impactful and insightful information that you need to know before you make your holiday plans or business plans or family plans with the upcoming season. And we really hope that everybody found value and can put these best practices in action to stay safe.
All right, we just want to again thank you for being here, and also say that as we go into the holiday, continue the conversation that we're on, share what you've learned with others, ask yourself, what can I do as one person to make a positive difference, not only for Thanksgiving, but over the holidays. And again, thank you for engaging. This will be posted at some point soon on the Brown Chapel AME Church website and also on YouTube, so that you're welcome to share it with others. We probably will have other events like this, COVID conversations, because we want to get this information out to you and other people so that we can be healthy. We don't want those numbers to continue to go up, and it's up to each individual to do so. Dr. Phillips, do you have a closing comment?
No, just thank you. Be sources of life. Share this information with everyone you know and love. Be sources of life.
All right.
Awesome.
Be safe, and thank you.
Guys.
Brian, you get the last word.
Be safe. Thank you. Happy Thanksgiving in place, and happy holidays in place.
In place.
And there will be future holidays if we do what we need to do now.
Absolutely.
So thank you guys, and enjoy the rest of your week.
All right. Bye-bye now.